This is Joe. Joe is a physical therapy student who works at his local hospital taking care of patients and performing rehab services. Joe is a diligent worker who follows all safety precautions and protocols. Joe always provides skilled, personalized care to each of his patients. But today, Joe's working on the cardiac floor and we want to know, what does a PT do with a cardiac rhythm? Here comes Joe now. Looks like his first patient has atrial fibrillation, characterized by a jagged baseline, generalized arrhythmia, and indiscernible P waves. Seems like our patient is fine, but Joe's not so sure. We better check the history. Generally, if this is not a new onset of the AFib, the patient should be okay to work with. Go on and get him out of bed, Joe. Good job. Most any level of exercise can be prescribed depending on the patient's ventricular rate. It's also important to monitor the patient's response to exercise. He's not looking too hot, Joe. Better set him down. Looks like he's gone into RVR, or rapid ventricular response, characterized by an elevated ventricular pace. Exercise should stop immediately, but don't freak out. Return the patient to bed and monitor very closely. Be sure to consult with cardiology and make sure emergency staff is on standby. Good job. Joe's next patient is having an episode of SVT caused by aberrant electrical activity in the upper chambers of the heart. SVT is a spontaneous rhythm that can be caused by any type of stress. The patient may exhibit chest tightness or shortness of breath. But what do? Physical maneuvers can be used to help this patient, such as positioning. That's not so good. Not that either. That's acceptable. Much better. Valsalva maneuver can also be used. Be sure to take a deep breath in, bear down, cross the arms and legs, and flex. Good. Positioning and Valsalva create what's called a vagal response. Maneuvers such as carotid massage or ocular pressure may be used, but they are not generally accepted. The length of SVT episodes varies among patients, and you may need to stop exercise if symptoms persist. And always be sure to document the incident. Working with his next patient, Joe sees this: elevated and depressed T waves indicative of myocardial infarction. This requires immediate attention, so keep the AED on standby, correctly place your paddles, and begin CPR if necessary. If enough time has passed and you keep good track of your patient, you may notice downtrending troponin levels with an accelerated idioventricular rhythm indicative of reperfusion in the heart. If this is the case, light exercise may be indicated, but beware of sternal precautions. They just had a heart attack. Joe now comes across a first-degree heart block characterized by an extended PR interval. Doesn't know what to do? Better check the history. The block isn't new and the patient is asymptomatic. All types of exercise may be indicated. Second-degree heart blocks are characterized by a further increasing PR interval or a fixed PR interval, followed by a dropped beat. Better check the history. Again, if the heart block is controlled, the patient may still be able to participate in mild to moderate exercise, but be sure to monitor their exertion. Good job. A third-degree heart block exhibits complete dissociation between the P and QRS complexes on the EKG strip. Depending on the history and the extent of the heart block, light exercise may be indicated, but it is likely they'll have a pacemaker soon to correct the block. Now that Joe's really in the heat of things, he encounters ventricular tachycardia, a self-perpetuating rhythm originating from the ventricles, which can also progress into ventricular fibrillation. Be sure to observe the patient's status. Generally, VTAC patients will exhibit shortness of breath, chest tightness, accelerated rhythms, and syncope. Make sure the patient is back in their room where emergency services can be provided if needed. Depending on the episode, the run of VTAC may be brief and the patient may return to light exercise very soon. Good job. Oh no. It seems our patient is showing no electrical activity on the monitor. But what's this? Joe seems to have overlooked a minor detail. Make sure all those EKG leads are placed properly, Joe. Missed one. Oh, there we are. Good job. Now remember, if it is true asystole, this is a non-shockable rhythm, typically treated with drugs, as well as CPR, although the prognosis isn't great. Joe has survived his day on the cardiac floor and has a whole new wealth of knowledge to share with his colleagues. He's excited. It seems our friend Joe here has really got the rhythm.